Welcome to Frontier Nursing University's 2020 virtual event. We're celebrating National Midwifery Week, and today's session is titled Racial Disparities in Maternity Care. Where do we go from here? I'm Tanya Nicholson, the Department Chair of Midwifery and Women's Health, and I'm honored to introduce our two presenters, Dr. Heather Clarke and Dr. Susan Stone. Dr. Heather Clarke has been a certified nurse midwife for over 40 years. Over the years, she has served women and families in a variety of clinical settings. She earned her Doctor of Nursing Practice from Frontier and currently serves at Frontier Nursing University as an assistant professor. Dr. Clarke has dedicated years of working on programs and projects in advocacy and public health aimed at reducing racial disparities and improving healthcare outcomes. Dr. Susan Stone has been a certified nurse midwife for nearly 30 years and completed her midwifery education at Frontier's first nurse midwifery distance education class. Dr. Stone has served as the president of Frontier Nursing University for the past 2 decades and is the immediate past president of the American College of Nurse Midwives. Dr. Stone has made it central to Frontier Nursing University's mission to diversify the student body with the ultimate goal of diversifying the midwifery and healthcare workforce. Welcome, Dr. Clarke and Dr. Stone.
Good afternoon and welcome to our sessions today regarding midwifery, celebrating National Midwifery Week. We're so glad that you're here. We want to congratulate you on your profession as being a midwife and all the very hard work you do. And I'll go ahead and get started with our session. So our session today is presented by, as you know, Dr. Heather Clarke and myself. We're going to be talking about racial disparities in maternity care. Where do we go from here? And we're going to give you some information that we hope that you can use to have some effect on improving the outcomes that we're seeing in your own community, in your own practice. So let's get started. So the objectives for this session are to identify disparities in healthcare outcomes, recognize how racism affects the healthcare outcomes of Black and Indigenous women and their infants, describe change theory and how it can be applied to the problem of structural racism and other racism, other types of racism as well, and then recommend at least 3 strategies that could be applied to improve the health outcomes for Black and Indigenous women. And we hope that there's even more that you take away from this than 3. Thank you. Next slide, please. So as you probably know, you may have even seen this slide before, it's been used a lot, but our maternal mortality here in the United States continues to rise. We have the highest maternal mortality rate of any developed country. We lose about 700 women each year to maternal mortality here in the United States. And as you can see from this slide, not only is ours rising, but you can see from the other countries, theirs is actually declining. So what's going on here? Next slide, please. So when you look at the pregnancy-related deaths in the United States, you can see the disparity in this rate. So about 13 per 100,000 live births for white women results in death, 30 for American Indian and Alaska Native women, but for Black women, it is 41 per 100,000, by far outweighing about 3 times the rate of women, Black women die as white women. So really a huge problem for the African-American population. Next slide, please. So we also see this problem with maternal morbidity. And as a matter of fact, you can see from this slide that as the maternal morbidity has risen across the years. This slide is actually looking at 2006 and 2015, with 2006 being the teal and 2015 being the blue. And you can see that the rates of maternal morbidity. So what is morbidity? So there's many indicators that are used. In some cases, did the woman hemorrhage? Did she have to have a blood transfusion? Did she have to be admitted to the ICU? And this happens in about 50,000 cases across the United States and happens much more to women of color than white women. Next slide, please. And we see this problem also crossing over into our infants. You can see the disparities in infant mortality with non-Hispanic Black at 11.4 per 1,000 births compared to white at 4.9. And really coming in again, the Black mortality rate for infants is the highest of any race. Next slide, please. And then we had the COVID pandemic occurring this year. And COVID disparities, we're seeing 2.37 times as many Black people died of COVID as white people. And there's many reasons for this, and we're going to get into those later in the presentation. So we have a problem. We have a very big problem with disparities, and why exactly that is happening. Next slide. So we have to understand that racism in healthcare is the driving force behind the disparately high rates of maternal and infant deaths and all the other poor outcomes for African American families. So I want to talk to you about some definitions of racism a little bit, and then I'm going to let Dr. Clarke delve into some of the reasons why this is happening in our country. So the definition of racism is the marginalization or oppression of people of color based specifically on their color, and it is a socially constructed racial hierarchy, and it privileges white people. Next slide. So there are actually 3 different types of racism. When we're studying how to make different and how to make changes, it helps to look at the different types of racism. Next slide, please. So the first that I'm going to talk to you about is structural racism. This is the interplay of policies, practices, and programs of differing institutions that lead to adverse outcomes and conditions for communities of color compared to white communities. And this occurs in the context of a racialized historical and cultural condition. So this is the big picture. This is our laws, our policies, things that happen across communities, across organizations, from that may affect many different organizations. And I'm going to show you a little bit more of that in just a minute. But this type of racism is fueled by predominantly white power structures that perpetuate power imbalances among people of color. Next slide, please. The second type of racism is institutional racism. So this would be more located within a certain organization. So if an organization is really assessing itself to see what types of practices are either benefiting or not benefiting people of color, these are the policies, the practice, and the procedures that really work to benefit white people to the detriment of people of color. And oftentimes these policies, it's invisible to the people who create the policies, and it may be totally unintentional that these benefit some people while not benefiting others. And examples when looking at this may be clinic hours that end at 4 p.m., no sick time or restrictions on sick time that don't allow caring for sick children using your sick time, and things like health or birth center policies that don't accept Medicaid. You can see how each of these can decrease access to care and make it more difficult to receive health care. Just a few examples, there's many, many more. Next slide, please. And the last type of racism is individual or interpersonal racism. Often this is what we think of most when we think about racism. This is prejudgment, bias, stereotypes, or generalizations about an individual or a group based on their race. The impacts of racism on individuals, white people and people of color, internalized privilege and oppression. So individual racism can result in illegal discrimination. This is also, it can be direct, aware discrimination. It can be unconscious bias where a person doesn't even know. You know, so many of us have just stereotypes in our heads. These are built into us from the time of being in our early childhood. But they interact with us every day of our lives. So next slide, please. So this little video is about a 3 to 4 minute video that I just think it really shows you what happens with structural racism and what are some of the outcomes.
This is Jamal. Jamal is a boy who lives in a poor neighborhood. He has a friend named Kevin who lives in a wealthy neighborhood. All of Jamal's neighbors are African American, and all of Kevin's neighbors are white. Because Jamal's school district is mostly funded by property taxes, his school is not very well funded. His classrooms are overcrowded, his teachers are underpaid, and he doesn't have access to high-quality tutors or extracurricular activities. Kevin's school district is also funded by property taxes, so his school is very well funded. His classrooms are never crowded, his teachers are very well paid, and he has access to high-quality tutors and lots of extracurricular activities. Kevin and Jamal live only a few streets away from each other. So how come they're growing up in such different worlds with such different opportunities for success? The answer has to do with America's history of systemic racism. To understand it better, let's look at what life was like for Kevin and Jamal's grandparents. Decades after the Civil War, many government agencies started to draw maps dividing cities into sections that were either desirable or undesirable for investment. This practice was called redlining, and it usually blocked off entire black neighborhoods from access to private and public investment. Banks and insurance companies used these maps for decades to deny black people loans and other services based purely on race. Historically speaking, owning a home and getting a college education is the easiest way for an American family to build wealth. But when Jamal's grandparents wanted to buy a house, the banks refused because they lived in a neighborhood that was redlined. So Jamal's grandparents were not able to buy a home, and because colleges could prevent them from attending through legal segregation, their options for higher education were really scarce. Kevin's grandparents, on the other hand, got a low-interest loan to buy their first house and got accepted into a handful of top universities, which traditionally only accepted white students. This opened up a wealth of opportunities that they were able to pass on to their kids and grandkids. Even as late as the 1980s, an investigation into the Atlanta real estate market showed that banks were more willing to lend to low-income white families than to middle or upper-income African-American families. As a result, today, for every $100 of wealth held by a white family, black families have $5.04. A 2017 study confirms that redlining is still affecting home values in major cities like Chicago today. This explains how Kevin and Jamal inherited vastly different circumstances. Unfortunately, the story doesn't end there. A big part of systemic racism is implicit bias. These are prejudices in society that people are not aware that they have. Let's go back to Kevin and Jamal. Against all odds, Jamal manages to be the only student from his high school to get accepted into a great university, the same one that Kevin and his high school friends are attending. But after Kevin and Jamal both graduate, Jamal notices that his resume isn't drawing as much interest as Kevin's, even though they graduated from the same program with the exact same GPA. Unfortunately for Jamal, studies show that resumes with white-sounding names get twice as many callbacks as identical resumes with black-sounding names. Implicit bias is one of the reasons why the black unemployment rate is twice the rate of white unemployment, even among college graduates today. You can see evidence of systemic racism in every area of life. The disparities in family wealth, incarceration rates, political representation, and education are all examples of systemic racism. Unfortunately, the biggest challenge with systemic racism is that there's no single person or entity responsible for it, which makes it very hard to solve. So what can you do? The first thing you can do is work towards becoming more aware of your own implicit biases. What are some prejudices that you might hold that you're not aware of? Second, let's acknowledge that the consequences of slavery and Jim Crow laws are still affecting access to opportunity today. As a result, we should support systemic changes that create more equal opportunities for everyone. Increasing public school funding and making it independent from property taxes would be a great start, so that poor and wealthy districts can receive equal access to resources. Systemic problems require systemic solutions. Luckily, we're all part of the system, which means that we all have a role to play in making it better. Peace.
Thank you. I hope that helps you understand how structural racism can have very deep and long-standing and cumulative effects. Next slide, please. So we know that all three types of racism affect both one's health and one's ability to receive high-quality health care. Next slide, please. So we have to be able to understand that racism really is the reason for these bad outcomes. And once we can acknowledge that racism is the underlying cause of the disparities, then that allows us to start to form solutions and strategies to move forward and do our best to eliminate racial disparities. That's our goal. Next slide, please. All right, now I'm going to introduce Dr. Clarke so that she can share some of her deep information and meaningful information. Dr. Clarke?
Thank you, Dr. Stone, and thank you so much for that wonderful overview of the current state of maternal child health disparities and racism in the U.S. and that powerful video that really highlights some of the things that I will be speaking about as I go through my talk. This New York Times article really says it all. We Black and brown mothers and babies are in a crisis in the U.S. And in my section, I'm going to briefly touch on the history of Blacks in the U.S. to help us as midwives understand how this present crisis has developed. And I intend to finish with naming a couple mechanisms, methods that we as midwives can use starting tomorrow to begin to do our part in addressing the disparities. Next slide. So, quoting Viola Davis, racism is built in the DNA of America. As long as we turn a blind eye to the pain and suffering under its oppression, people of color will not escape these origins. The promise of the civil rights has never been fulfilled. Next slide. And what is that history? Well, starting with over 400 years, Black folks were captured and chained. Next slide. Survived in the middle, the transatlantic slave trade beginning in 1619. Next slide. Sold and separated from families. Women could not protect their children. Men could not protect their children or their women. Next slide. Forced to work long, hard hours with no pay, and children were also forced to work, and a variety of pretty torturous devices were used to keep them in check. Next slide. And of course, there were the hang-ins, the slay-ins, the burn-ins, and many of these took place as a public spectacle, entertainment. Next slide. And unfortunately, these murders and lynchings are still going on today. Next slide. And I'd like for you to join me in taking a deep breath as we bring our nervous systems back into regulation after those disturbing images. Next slide. So institutional, structural, and individual racism, as Dr. Stone mentioned, are not new. She spoke about emancipation, Jim Crow, segregation, Reconstruction. Today we call these social determinants of health, and they have resulted in Black and brown people living in very poor, impoverished neighborhoods with decreased public services, poor schools, poor access to health care. I'm not going to go through all the things on here, but limited food sources, neighborhoods with crime and gang violence, mandatory prison sentences that lead to higher rates of incarceration with Black men so that women don't have their partners available to them as much as they would like during pregnancy and childbirth. Violence and murder from the police, leaving an incredible amount of fear in the community, low paying jobs, people have to work 2 to 3 jobs. And no political representation. And finally, I want to mention segregation and gentrification, which has basically resulted in a dismantling of continuous supportive communities with the traditional support of the church and families that many pregnant women no longer have. Next slide. So post-traumatic slavery disorder is a term coined by Dr. Joy DeGray, who describes it as America's legacy of enduring injury and healing. And this has led to a vicious cycle of weathering, health disparities, and major chronic health diseases like diabetes, hypertension, renal failure, more commonly experienced among Black and Brown people, not because we have a genetic disposition to that, but because our circumstances over the years have made us more vulnerable. Post-traumatic slavery syndrome is a continuation of many maladaptive thoughts, beliefs, and behaviors passed down from previous generations, and often involves poor dietary habits, lack of trust, self-hate. That's that internal racism that can express itself as self-hate, distrust of whites, anger, despair, broken families, missing fathers, single mothers, and ongoing community destruction and segregation and predatory lending. Next slide. And we used to think that events like obtaining a college degree or coming to money and wealth and social status or marriage could protect Black women in the process of pregnancy and childbirth and postpartum. And we're finding that is not the case. Even wealthy, well-known people like Serena Williams reported that in the midst of her pregnancy and postpartum period, no one listened to her complaints. They were dismissed. She got no respect and definitely no love. Next slide. So racism is the underlying cause, and that can be racism expressed directly or vicariously through other family members. And inside the womb, fetuses are exposed to vicarious racism through their maternal experiences. And this accumulates over a lifetime, more for African Americans, leading to a greater state of allostatic or toxic stress. Next slide. So we know that the stress response is a natural process. It's a normal adaptive process which enables an organism to quickly respond in the face of stress. This is a fight or flight response that we're all familiar with. And the response, the physiological response to stress, can be as a result of real stress or perceived stress. So when a major event takes place, the body will respond with a cascade of events that result in increased circulation of cortisol, catecholamines, and a number of pro-inflammatory cytokines. And when the stress is over, normally the organism, those high circulations of stress hormones decrease, and the organism returns to an adaptation, and homeostasis is achieved. Unfortunately, when the stress load is high and there's yet another stress to deal with, and understand racism is perceived as constant, persistent stress. So Black and Brown people are more likely to reach a state of allostatic load, which has a significant impact on the entire body. Next slide. So this is a healthy response from the stress system, which is largely controlled by the lower brain, the hypothalamus and the amygdala. So when there's a trigger, the sympathetic system kicks off with stress hormones, and then things settle down and the organism returns to a state of balance. So this is where we want to be, right? We want to live in this range of adaptation. Next slide. Unfortunately, for many Black and Brown bodies, they are so used to persistent cumulative stress that they have these huge swings of activation and then coming down, oftentimes living in a state of hypervigilance, anticipated stress or anticipated racism. And they can easily become stuck on where the sympathetic nervous system is firing and the load of stress hormones are constantly circulating within the body. This can lead to states of anxiety, panic, hyperactivity, inability to relax, restlessness. I mentioned the hypervigilance, emotional flooding, hostility, and sleeplessness. And you can imagine if someone is pregnant, this is not a healthy set of responses to live on a daily basis. Or one could become stuck on off, where the body is just unable to respond to stressors anymore. It just like turns a blind eye. The parasympathetic nervous system definitely takes over. And in somatic experiencing, we call that a state of parasympathetic freeze, where one can become depressed, affect is flat, lethargic, chronic fatigue, disorientation, lack of appetite. Again, not healthy behaviors for a pregnant woman. Next slide, please. So this all leads to weathering, which I mentioned before. And looking from a life course perspective, weathering is really just the wear and tear on the human body from repetitive experiences of stress and racial discrimination or a state of hypervigilance. And the autonomic nervous system is unable to return to a state of balance. And now we also know that added to that state of persistent stress is the load that we inherit from transgenerational trauma from our ancestors. So Dr. Liu, back in the early 2000s, wrote a lot about cumulative stress, allostatic load, and looking at the reproductive potential. And what he documented is that even if we assume that Blacks and whites start at an equal place with no accumulation of transgenerational trauma, that Blacks represented on the dotted line tend to have less protective factors to the daily stresses, the multiple daily stresses that they experience in their lives, as opposed to white women who don't have as many daily stresses, but have significantly more protective factors from their environment. So their reproductive potential and their state of health throughout the life cycle is much greater than that of African Americans. Dr. Imani Allen, Associate Dean of Berkeley, has done more work in the area of weathering, looking at predictive probability of individuals, and she broke the individuals up by race and sex, where individuals have their potential to experience allostatic load. And she found that overall Black women have up to 5 times greater potential to experience allostatic load, so a state of over stress in their bodies, as opposed to Black men, white women, and white men. Next slide, please. So just to show you real quickly how a state of constant stress and allostatic load impacts the body when the body is stimulated, when there's a trigger. With the stress hormones, we want to fight or flight, right? So the cardiovascular system, the respiratory system, and the muscular skeletal system, they are upregulated. They get more blood and more oxygen so that they can react and get away from the stressor. And at the same time, other bodily systems like the digestive system, the reproductive system, and the immune system are more likely to suffer from a lack of blood flow and oxygen. And as we can imagine, this is not a healthy state in pregnancy, where there's potentially a decrease in uterine blood flow. Next slide, please. So another way to look at stress and the impact of long-term weathering upon age is to look at the telomeres, these purple caps at the end of the chromosomes. So this work was discovered by Dr. Elizabeth Blackburn in 2003. She won a Nobel Peace Prize in physiology for her groundbreaking work in telomeres. So the telomeres are caps that include a repetitive sequencing of non-coding DNA that forms the caps that protect the integrity of the cells so that they can continue to function and carry on their physiological functions to maintain life. And unfortunately, we know that telomeres, the length of these caps, decrease with age, and that decrease, the decrease in the length of the telomeres is accelerated by cumulative stress over a lifetime. Next slide. So just to bring your attention over to the right side, what we know when we look at telomere length over the course of a lifetime, if we compare white males to Hispanic and Black males, that over the course of time with the exposure to excessive stress, Black and Hispanic males tend to have shorter telomere lengths than white males. And on the bottom, we see the same thing repeated in women, where Black and Hispanic women have shorter telomere lengths than white women. As a matter of fact, the difference here is even more pronounced. So there's something going on over a lifetime that impacts the length, the health and longevity of Black and Hispanic women. And we have come to recognize the underlying cause as stress. Next slide, please. So how does this relate to pregnancy? So the Association of Pre- and Perinatal Psychology and Health have done a lot of work looking at epigenetics and transgenerational influences. And we know, and a lot of this is backed up by research from researchers up at Columbia and other universities around the country, that stress can be transmitted 3 to 4 generations back and 3 to 4 generations forward. So this FO may be a pregnant woman that you as a midwife is caring for, and her baby is F1, and inside her baby is, of course, the ovaries and all the eggs, and inside those eggs is the potentiality to make a whole other generation. So that woman that you're caring for, the outcome of her pregnancy and just her entire life stress and health in general can have an impact on her great-great-granddaughter, somewhere in there going forward. And she can also be impacted by her great-great-grandmother, at least 3 to 4 generations backward and forward. Michel Audin, in his latest book, The Future of Homo, kind of reminds us of this in a really subtle way. We know that 50% of the chromosomes are directly inherited from the female, but what we're just learning is that within that transmission of chromosomes is hundreds of years of the education of those chromosomes as a result of those eggs living inside generations upon generations and picking up on the cultural events and the social environment and the events that are taking place through the course of that woman's lifetime. Next slide, please. So epigenetics is deeply influenced by environmental conditions, diet, chemicals, poverty, stress, and relationships, as well as just environmental conditions in general. Next slide. The mechanism of epigenetics starts with a trigger from the environment. We know that the mother is the first environment for a human embryo or fetus. And when an epigenetic impact takes place, it alters the way DNA is transcribed to the RNA, as well as the methylation of the nervous tissue. And this is all controlled by tissue-specific gene-regulating proteins. And those proteins can be expressed in utero and impact the way the fetus develops in the program in an imprint, and it takes place both on a physical as well as a behavioral level. And we know that the impact, the effect of epigenetics is greater during cell division. Kind of makes sense, right? You have all these cells dividing and there's some kind of epigenetic insult and more cells, and what happens down the road is impacted. And periods of greater self-division, of course, is in utero when that fetus is growing, early childhood, puberty, and pregnancy. Next slide. So this is just depicting some of the intrauterine impact of stress when there's a trigger, just like the mother with the increase in cortisol in the bloodstream, the baby can experience an increase in heart rate, blood pressure, decreased uterine blood flow, and at the same time, decrease immune function, increase blood cortisol level because the load of cortisol is able to overwhelm the placenta protective mechanisms that the body has. Amazing how the body functions. Next slide, please. And this slide is to show you one of the major critical periods of growth that we as midwives are all definitely concerned about, and that's the period of embryology. And what I find fascinating here, these dates are per LMP. So if we take 2 weeks away, we know that as early as 3 weeks gestation, the central nervous system and the heart and cardiovascular system have started to form and function in a very rudimentary way in the embryo. So if we don't prepare the woman and her family for pregnancy to conceive, these whole first semester actually, but particularly this early development of the heart and the brain, we can miss a critical opportunity to make sure that that fetus has the best environment to develop a good, healthy cardiovascular and neurological system that will serve it way into adult and avoid chronic health problems. Next slide, please. So this is Denise. Just want to share her with you. Denise, unfortunately, represents many women I've cared for over 40 years of being a midwife. She's a 24-year-old gravid of 4, para 1022, 27 weeks. You're seeing her at 27 weeks. Her first visit was at 23 weeks, and she had a sonogram at the time, discordant growth. She is pregnant for a new partner who she's been with for about 3 years, who's been wonderful to her and her sons. And unfortunately, a week after her visit at 23 weeks, he was arrested for and incarcerated for some minor infraction. And now that you're seeing her, her blood pressure is 170 over 106, 2+ pedal edema, 3+ proteinuria. Since her partner was incarcerated, she does live in a high crime neighborhood. But she became homeless over that time without his support, and she lost her job, just taken off from normal pregnant complaints and having to care for her 2 sons. She doesn't really have any close relatives, and she was more concerned about trying to find food for herself and her children and somewhere to live than coming to the clinic, which meant walking through some dangerous city streets and finding bus fare for the 3 of them that she just could not get to the clinic. So how we know that she has some serious high risk issues. So the question to all of you is, how do you as a midwife relate to this woman? Do you just, pass her off because she's high risk and send her to MFM? Or do we stop for a minute and think about how our system has failed this woman? How it has not enabled her to have good access to care that is available to her, and enable her to be able to get to her appointments and have the kind of support that she needs, whether or not her partner is there to assist her. So when we see women like this, and their story may not be extreme as Denise's, we need to stop and think about the larger picture. How did she get to this place that is so desperate and so high risk for both her and her baby, safely coming through this pregnancy in a healthy way? Next slide. So I do not claim to be an expert on how to address maternal and child health disparities. I am sharing with you some of my experiences and what I have learned from the literature. I do want to put a shout out to the American College of Nurse-Midwives. In April of this month, they put out a joint statement with Black Mamas Matter, to address and acknowledge the health disparities. And Black Mamas Matter continued with programming for the entire week of April, where they partnered with many of these organizations that are listed here and more. So I put this slide up here to let you know that there are many groups working on this problem in case you want to reach out to any of them. But this is a national crisis, and we all have to do our part to make a difference. Next slide. So as a midwife, I go back to the hallmarks of midwifery. I'm sure many of you do too. And some of my favorite are in purple: recognize pregnancy and birth and menopause as normal physiological and developmental processes, promotion of family-centered care, and my personal favorite, therapeutic value of human presence, being with the woman, listening to her, respecting her. And there are others on here that I'm sure some of you are being called to, and know that as we try to address these health disparities, that many of these hallmarks definitely come into play. Next slide. So as we look for some potential solutions, I want to take this moment to quote Resmaa Menakem, who calls himself a somatic abolitionist. And he says really clearly that to Black folks, when he works with them, there's nothing wrong with us. We are not defective. And that is true. Our present condition, our health crisis, is a result of over 400 years of systematic, structural, institutional, and individual racism. And we're finally coming to the point where we recognize this, and we recognize that Black lives matter, every life matter, and everyone should have the opportunity to have a healthy pregnancy and a healthy mother and baby and family. Next slide. So my answer to that, and the CDC's answer to that, is preconception care and planning ahead. And we know whether you're Black, white, pink, or yellow, folks just don't run to get preconception care. We know that 50% of pregnancies are unplanned. So we as midwives, if we want to really incorporate this and promote it to our clients, we have to do outreach. We have to involve as many community agencies as possible. During my work in public health in Brooklyn, when we were trying to get women in, and it wasn't even preconception care, it's just to get them into prenatal care and early detection for developmental issues with their children, we canvassed the community, and we got all kinds of community businesses involved, including barbers and beauty parlors, so that when women came in and you strike up a conversation with your attendant, we teach the attendant how to ask about their family, and whether or not, and if they discover that she's pregnant or planning to be pregnant, we ask them to refer her to our agency, where we could plug them into all kinds of resources that they might need, including food and items for their baby, and counseling and housing. That was a biggie, to make sure that their stress is decreased during pregnancy. Next slide. So the goals of preconception care, I would say the number one goal is to assess the mother and the couple's hopes and dreams and concerns for their pregnancy and expanding their family. And what is their timeline? What is their relationship? That is huge. We know as women and as midwives, the women we see, their relationship with their partner really impacts, for many, many women, I'm not saying for all of them, their state of well-being, their state of health, whether they feel safe and protected for. So it's important to assess that relationship and do what we can to provide counseling, and if we have to, refer them. We also, of course, want to screen for genetic and medical issues. This is back to assessing the relationship, assess for trauma and transgenerational or current trauma, and of course, make sure they're on the important supplements and I like to really work with couples on connecting with their unborn and doing some ritual around that. Next slide, please. So if your client is Black or Indigenous, Black or Brown, assume that there has been PTSD and intergenerational trauma. And your first step is to build trust and provide that safe, welcoming environment, build trust in the relationship so that they can open up to you, because we want to begin to mitigate that stress as much as possible and the way the body is functioning with that stress as much as possible before they get pregnant and even early in the pregnancy. Remember, week 3, the heart and the brain start to form and function. So what is her support system like? This is huge. It breaks my heart over the years when I see pregnant women coming alone with their toddlers and they have no visible evidence of support around them. So let's help them build layers of support. And if they start that before the pregnancy or early in the pregnancy, when they're 2 weeks postpartum and they've lost it, right? They have people they can call up to bring them food, take care of children, or whatever they need. Provide a safe place, a nesting place. And it's important for us to do our own work, identify our own biases, our own stresses, and how we interact with people who are looking to us for support. Definitely respect the partner and accept their input, whether they're male or female. Respect boundaries. Sometimes it's not just about educating people. What do they already know? If their lives are over up to here in stress and you're educating them about hygiene and pregnancy, they're not going to hear you. So we have to address those stresses and make sure that they get the resources and the support they need. Next step, slide, sorry. Back to basics, make our offices, our clinics as friendly as possible for all of our clients, and for those Black and Brown clients, again, listening, respecting, encourage a sense of pride and strength, empowerment. Some people want to do DNA testing so that they can celebrate some ancestral connections. And if you're able, bring in ritual, bring in the family, have them bond. There's some old African traditions where there's a lot of focus on bonding, even preconception, but absolutely during the pregnancy. Family members bonding with that spirit of that incoming so that they're more prepared to be there and support that child and that family as it grows. Next slide. So, and the same carries over in preconception care. You want to encourage, empower shared decision making, have them reflect on their own parenting. Are there things that they want to change or continue? Talk about different styles of parenting, and educate them about the embryological development, fetal development. If people know what's going on inside of them, they're more apt to follow some of your advice around diet or sleep or stress reduction, things like that. So these are just some methods of stress reduction: mindfulness, movement, humming, multiple that I can't go into right now, and honor their resilience, right? What have they overcome? And also honor their silence. Sometimes people just need to be in their space before they feel safe to open up. Next slide. And last thing, just to touch again on layers of support. It really does take a village. And those village may be organized structures like WIC, Nurse Family Partnership, the health department, community advocates, police enforcement. How do you work with the law enforcement in your community to help them switch to where they're protecting consumers rather than harming them? Churches and mosques, we know traditionally have been great places for support, so reach out to them. Next slide, please. And going back to Dr. Liu, he proposes that if we as providers and social support agencies increase the amount of supportive methods that we give to Black women, that their level of productive potential, their life potential will increase, and the gap between whites and Blacks will decrease until one day it disappears. That would be a great goal. Next slide. And this is some information from the CDC. We know that people don't come in jumping up and down for preconception care. So they promote whatever you're seeing them for, whatever they come in for. You do your history, your assessment. Oh, is there any possibility you might be pregnant or thinking of being pregnant in the next year? No. Well, from your history and physical, these are some things that I've identified that it would be really good for us to work on to help you become more healthy and be there for your family and your partner and yourself. So let's think about some long-term birth control so we can work on these things like your blood pressure, your diabetes, and you don't have to worry about pregnancy along the way. And if the answer is yes, oh, well, there's some things that I found in your history of physical that would be really good for us to work on before you get pregnant. So let's think about a short-term birth control so that we can have 6 to 9 months to really get your weight into a safe zone, to get your blood pressure to a much healthier place through diet and exercise and your diabetes, whatever. So next slide, please. This is the CDC's preconception website called Before, Between, and Beyond. And it's a place where you can go and find out a whole lot more information about preconception and lots of tools that you can use to integrate right away into your practice. And at this time, I am going to turn the mic back over to Dr. Stone, who is going to walk you through a step-by-step process using change theory to help you think about how you might be able to institute change within your practice as a midwife. Dr. Stone?
Thank you, Dr. Clarke, and thanks for that really enlightening description of the stress and weathering experienced by people of color and the long-term effects. So how do we make change? First, we have to really know that racist policies are not indestructible, racial inequities are not inevitable, and racist ideas are really not natural to the human mind. And we have to believe in the possibility that we can transform our societies to be anti-racist from this day forward. That a direct quote from Ibram Kendi. Thank you. So what is the alternative to structural racism? When social, economic, and political opportunities and outcomes are not predicted upon a person's race. Next slide. So what I'm going to do is kind of take you through a change process that comes from the Aspen Institute, and it is a racial equity theory of change. And it's just a series of steps that will help you to make some changes in your own practice, your own environment, your own state, or even the country. So first of all, step one, what do you want? Define your desired racial equity outcome. Next, set priorities. Identify what are the building blocks of your racial equity outcome. Step 3, what supports or impedes your building blocks? Step 4, mapping the local change landscape. And step 5, what you must do. So let's look at each of these steps. Next slide. So first of all, what can you focus on? What is it that you really want to change? Whether it's public policies such as Medicaid expansion in your own state, how can you address that? There are ways. Who can you join? Who are your partners? All of those things. Maybe increase the number of midwives. This is an agenda of mine, working in various task forces and different agendas on how to increase the number of midwives. And also looking at specific legislation. It may be a specific agenda within your state. It may be independent practice for midwives so they can be more effective in their practice. Whatever it is that you really want to focus on. Think about what you want to focus on. What are social and institutional practices? So now we're down to more institutional issues. It might be you want to expand the clinic hours and to meet the needs of your clinic, or implementing telehealth so that people don't have to travel so much and come to every appointment, or adding home visits. And then cultural representations. This is could be training staff in unconscious bias, and also assuring inclusive media, which Dr. Clarke did mention, just creating that really welcoming environment in your clinic or your setting. So next slide. So step one would be defining what is it that you want to do, and create an outcome statement that specifies what racial disparities or what is the issue that you would like to reduce or eliminate in a given place in a given time frame. Next slide. So think about this. Is there one specific area of racial disparity within your setting that you would like to eliminate? And what scale is it that you want to see change? Is it individual, institutional, structural? And what would that outcome look like? If you were able to implement change, what would the outcome look like in your area? And is there any way that you can measure the racial goals? And what is the time frame that you're talking about? These steps are not totally new to you. We use these steps in our assessment as midwives, but this is specific for racial disparity. So next step, slide. So here is an example of an early first step racial equity outcome. Say you want to take your clinic environment, the clinic that you practice in, and have it be more that it would actually facilitate an equitable access to care for all women. So many of the policies, when you look at this, this is not specifically saying to Black women, but if you create a more accessible clinical environment, it will give more access to Black women and to other women as well. So this is a more general. Let's go to the next step. So are you thinking about this? What must be in place for this racial equity outcome to become a reality? What are some of the smaller building blocks that will have to be in place to make your clinic more accessible and more equitable? And what barriers are you going to encounter along the way that you can think of right off the top of your head that you might need to eliminate in order to be successful? And then sometimes there may be a long list in your initial brainstorm of what you want to change, and you have to prioritize. What can you do first, second, third? What's doable? What's a thing that you can accomplish? Next slide. So this is just an example of kind of a brainstorm list if we were trying to make this clinic more accessible and more equitable. So the first thing you might want to think about is increase the diversity of the staff. We know that when we have staff members that look like people, we have better outcomes. You might want to ensure standardized evidence-based guidelines for care and assessments. We know through the AIM project and the bundles and improving maternity care that when you do things in a standardized way, you decrease the application of bias to a situation and outcomes improve. You might want to create layers of support, such as Heather has already talked about. This can be doing a community assessment to see what issues are available already. Is WIC available? What are the support systems that are available in your community? Are there breastfeeding support groups? Whatever that might be. And then also looking within your clinic, maybe you're going to implement centering as a way to create layers of support, or a postpartum support group, or breastfeeding support group. Those kinds of things can help. The next, you might want to try to expand the clinic hours so that there's evening hours and Saturday hours. You might want to provide on-site access to financial counseling or Medicaid application. You might want to provide, you probably will want to provide ongoing diversity, equity, and inclusion training to all staff members. This is becoming actually in some states, this is being required to renew your licensure. So this may be an accessible goal today where it might not have been 10 years ago. And you might want to implement telehealth so that people don't have to come to every visit. You can check on them through telehealth, and it decreases the burden for coming to clinic. So next step, next slide. So for each of these building blocks, you have to apply a structural racism litmus test. Is this particular issue really having an effect? And really, if you did change this, would it increase the accessibility for women of color to come into your clinic? Would it make your clinic more equitable and more accessible? And then you have to identify what are the policies, practices, and cultural practices that are likely to determine whether this block remains in place or not. Is this something that you can change? Can you change the policies? Who has control over those policies? And what kind of change can you make? And remember that common assumptions can influence the creation of policies. And things like, just even go back to providers don't want to work evenings. Maybe providers do want to flex time. So just, avoid that trap of, oh, just because it's always been this way, or just because we assume this is a better way, but dig deep and look to what are creating the most barriers. Next slide, please. So you must understand the politics of power and change within your community. Who has the power to assist you to make change, and who might put impediments or blocks up for you? You have to remember that racial equity work is a political as well as a technical and programmatic effort. And you need to build alliances. Who are the people that are going to help you? What relationships will help you to make this happen? And productively counter resistance. Next slide. Next slide. So who are the key players in your community? How does governance work? How do changes happen at your community, in your clinic, in your setting where you're trying to make change? And again, look at possible sources of retrenchment. What are the things that are going to make this hard to change? And are you likely to be able to make this change? Are you able to address this retrenchment or the person, policy, or issue that's in your way in order to have success in your change? Next slide. And so in the end, you assess your organization capacity realistically, and you start to set priorities in that whole list of brainstorming to see what you can do. Decide what role that you can play, set your priorities, identify your allies, and go ahead and take action. So let's look at that list one more time. So looking at this, decided, yes, I can ensure standardized evidence-based guidelines for care and assessments. We can go back. There's a lot of data to support that this improves care. And of course, the clinic wants to improve care. So through provider relationships, provider groups, provider education, this is a possible implementation that can be done. Creating layers of support, looking at who are the people in the community, who are the support persons, making sure you have policies that welcome her mother, her children, her husband, her partner, whoever, into the situation, who is her family, to come to clinic visits, participate in care, those kinds of things. Providing ongoing diversity, equity, inclusion training is probably something that's within reach. Expanding clinic hours to evenings and Saturdays might be a little bit harder, although starting to do cost analysis, would you get more patients in the clinic if you did this that would offset the cost? Are there people that are willing to work on different shifts and flex their hours? So it may be a little bit more of a stretch, and it may have more issues that you have to deal with, but still willing to keep in the list, but might take a little bit more work to make it happen. Providing on-site access to financial counseling and Medicaid application. This is very doable and may provide better reimbursement to the clinic, and just having someone there to help figure out how they're going to pay for their care, whether it's through Medicaid or other, may be a very attractive service that you can provide that will help the clinic and help the women who are receiving the services. Increasing the diversity of staff may take more time. it becomes a strategy and a goal, and it may take turnover, but it can also be done by some of the things that Dr. Clarke said, which is add other members of the community. I remembered that Dr. Ruth Lubick's birthing center in DC, some of her women who actually had their births at the birth center ended up being employed by the birth center, either as breastfeeding advocates or just peer mentors for the teen women in the clinic. So looking at, it doesn't always have to wait until you can have providers changing, but you can have other people in the clinic. And last, implementing telehealth. This, right now during COVID, we've seen better reimbursement, relaxation of policies for reimbursement, and this could be a strategy that could really open up the clinic. So you can see how this list could go by these guidelines, set some timelines, set some goals, and go ahead and make changes. This is just one example. I know that you can do this in many areas of your practice, and you can use this strategy devised by the Aspen Institute to make change. So I hope that you'll find this useful. And I'm just going to turn it back to Dr. Clarke so she can close out the session. Thank you so much for your time today.
Thank you for those wonderful steps, Dr. Stone. The only thing I would like to add is a special plea to each of you who routinely work with entry-level providers, many of whom are Black and Brown. Look for those who are willing to go the extra mile for your clients, who show compassion and concern, and talk to them. Where are they in their lives? Perhaps you might consider encouraging them to become a midwife, planting the seed. There are only about 20,000 midwives in the US. We need more midwives, especially those who are Black and Brown. Thank you all very much.